Good evening and welcome to Doctors on Call. I'm Dr. Mary Owen, faculty member within the Department of Family Medicine and Biobehavioral Health and director of the Center of American Indian and Minority Health at the University of Minnesota Medical School. I'm also a family physician for the Fond du Lac Band of Lake Superior, Chippewa, and I'm your host for our program tonight on end of life and advanced care planning. The success of this program is very dependent on you, the viewer, so please call in your questions or email them to ask@wdse.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Jeff Copeman, a family medicine physician with Fairview Mesaba Clinic in Hibbing, and Dr. Amy Greminger, a faculty member at the University of Minnesota Medical School, and internal medicine specialist with Essentia Health. Our medical students answering the phones tonight are Katie Benson of Staples, Minnesota, Katie McLaughlin from Hibbing, and Abby Rader of Glencoe, Minnesota. And now on to tonight's program on end of life and advanced care planning. Thank you both for being here. Dr. Greminger, let me start with you. We have a couple of questions, but I want to know from you, why is this topic so important? You're an internal medicine doctor. I think you have some insight on why you're here tonight. Why is this topic so important to you?
I love talking about this topic because I really think it's so great to focus on the patient and what they want with their life. And so the opportunity to talk to patients and plan with them what their wishes are, what their values are, what their hopes are, what their desires are, really puts the control back in the hands of the family. And that is so rewarding to be a part of. So I always love talking about this.
Epitome of patient-oriented primary care.
Absolutely.
Yeah. Mm-hmm. Dr. Copeman, anything to add to that?
Yeah, it is such an important part of medicine right now. What we've run into is there's a lot of patients that actually have not even considered advanced care planning or advanced directives, and I've always been of the firm belief that it's easier to make decisions when you're of sound mind and body to make those decisions, should something come up where you're incapacitated and you're forcing a family member to make those for you. And so I spent several years doing primary care, and we actually have started doing that now as part of our office visits. So that's how important it is. And it's never too late to talk to your loved ones about what your wishes are should you develop a terminal illness or become incapacitated. What's
too early? When do you start talking to people?
Well, a lot of times we recommend even in the 40s or 50s. Mm-hmm. I've always told my patients in primary care that that's one thing you should do around your 50th birthday is start your advanced care planning.
Mm-hmm. And even sometimes I've mentioned it earlier because we just don't know what life is going to bring.
We don't. We really don't.
And even just to get people used to that conversation, that it's a norm.
Yes.
That you get to control the show and this is part of it, what happens to you at the end of life.
I so agree with you. You know, I think sometimes it's not something that younger people necessarily think about. But if the last couple of years have taught us anything, it's that anything can happen at any period of time. And so it's not necessarily spelling out all the intricate details that you might go into later, but knowing kind of what you want in general and who might be a good person to help if you weren't able to express that, and getting the opportunity to talk to that person about that and make sure that they're okay with that role, all can be such helpful things even for younger people as well.
And a lot of times it's been a topic that's uncomfortable for patients to talk about. A lot of times if we bring that up, they say, well, is there something wrong with me that you're not telling me? Am I dying? And now that we've had time and effort to try to get those in advance, it's making things a lot easier.
People are just getting used to it being part of the conversation.
Getting used to it being part of the conversation.
They don't assume anything bad.
Yep,
right?
Exactly.
Yeah. And yet we have seen, like Dr. Greminger, you just mentioned the past 2 years, we've seen some tragedies because people were not ready for death. And not saying that they should have done this, there's no blame at all. It's just that so many people, I think, were caught unawares.
Absolutely, and that's why I love these conversations, because it really is about control and putting that control back in the hands of patients and families. So again, just knowing who might be a good person to talk to about what you might want if for some reason you were unable to talk for yourself. I think even that one piece of information is so helpful for people.
Dr. Copeman, we have a question from the audience. What is an advanced directive and what things go on one?
That's a very good question because sometimes that can be very complicated. What basically in general an advanced directive is you're telling the healthcare system what you would like done in the case that you become severely ill or terminally ill. Now, there's different kinds of advance directives. You may have heard of a living will, a durable power of attorney, a pulse, and I'll try to explain those, and Amy, I'm sure, will help me. But in general, that's what an advance directive is. Now, the subparts are basically what we call as a living will. And a living will is tell exactly what you want done, and that can include what's called a durable power of attorney, which is someone you've designated to make decisions for you should you become incapacitated.
So in other words, the directive is just the overall message of how you want to direct your care at the end of life.
Exactly.
And then the living will is exactly what you want done as you come to the end, and durable power of attorney is someone who helps you get there.
Right. And the other thing that's come recently is something called a pulse. And I know that's a term, and it stands for Physician's Orders for Life-Sustaining Treatment. Because with previous advance directives, it wasn't a physician's order. And so even though someone may not want to be resuscitated, if an ambulance would come, they would have to do it anyway until they get the physician's order. So in order to prevent a lot of that, the groups got together and they developed this pulse, which actually is signed by your physician, and it goes through all the details of what you would want done, whether you want to be resuscitated, and if you don't want to be resuscitated, exactly what you would want done. And it's signed by a physician, and it's taken as an order.
So do you need both the pulse and the living will?
You don't have to, because some of the components of the living will are in the pulse itself.
Okay, but you can have both.
Yes.
And what are they usually? They're usually signed by your doctor, so the doctor would know if they were different.
Yep.
In any way.
And a witness in the living will a lot of times goes through an attorney's office also.
Okay. Do you have to have an attorney?
No.
Okay. I think that's an important point for people.
It is an important point, yes.
Yeah, they worry about costs.
Absolutely. And I think, whenever you have legal words, and I think it's always a little challenging for people to think about. So when we talk about about power of attorney, specifically in this context, what we're talking about is really somebody to make your healthcare decisions for you. And that's what we call a healthcare power of attorney. That is oftentimes, for many people, that's the same person that might make their financial decisions, but it doesn't necessarily have to be. And so I want to make that distinction, that you can choose somebody to help with your healthcare decisions. It doesn't have to be the same person as who would help with financial decisions if you weren't able to do that.
And that's confused a lot of times.
It is, and it's confusing.
Yes.
For patients. And so this is, because it's specialized terminology, I think that's another barrier that sometimes people experience. And that's why it's helpful to just talk about it and say, well, what does this actually mean? And go through that process. And people are happy to help you through that.
So our audience should know tonight that they can ask their doctors, if their doctors haven't brought it up, they can ask their doctors about all these questions that they have.
Absolutely.
And ask them to even write it out or make it really simple for them, or direct them to someone in the clinic who might be able to.
Yeah, and I know in the clinic that I work at, we've had several people who are actually certified in advanced care planning. And they take the time to go through all the details of what advanced care planning is. And not that you make any decisions right at that time, but at least it's an informed one that you take home and then can come back and meet with them. So it's a really good thing.
It's a nice process.
Yep.
So it's another thing to ask if your clinic has that person specifically.
Yes, exactly. Especially if there's a lot of questions about it.
Mm-hmm. And this person has a question that's very common. I'm having a difficult time broaching the subject of end-of-life planning with my aging parents. How do we approach and work through this? And I'll start with you, Dr. Copeman.
I think the most important thing is, yes, it's a family issue, but a lot of times it's good to have your physician initiate that. Because I think that we're able to outline better what prognosis is. We can discuss what terminal illness means. We can discuss what all the details of the advance directive mean. And there's a lot of miscommunication out there. One of the things I used to see quite often is that when someone was asked to do an advance directive and they decided to be what we call a do not resuscitate, they would assume that we don't do anything. Mm-hmm. And that is not true. I mean, it basically what a DNR means, or do not resuscitate, is that if you're already gone, we don't do anything to bring you back. It doesn't mean we stop all your meds. It doesn't mean we do anything. And that's a big misconception. That's why people would not want to sign it.
That's such an excellent point that I've had patients confused by. So in other words, if you are trying to broach the subject, consider having your healthcare provider with you.
Yes.
Not in other words, is exactly what you just said.
Yep.
To help you, or one of the providers in the clinic, or one of the people in the clinic who might be specializing in that.
Yeah,
Okay.
and Medicare actually has a specific code that we do as physicians for advanced care planning.
Okay.
I think that that's such a great question and that's a very common concern, that a lot of times this is really hard for people to talk about, which is why sometimes a third party can be helpful. I think it's also, whenever you go to have that discussion about something that is challenging, it's helpful to think about why you're doing it in the first place and what's the advantage of it. And there are many advantages. I would say the first advantage is to the patient themselves, that the patient gets to be confident that they will get the kind of care that they will want. And that is a gift. But there's also huge benefits to the family about this. And that's important to consider as well. Because sometimes what happens is that families don't know what people want, and then they end up making decisions, and that can be really distressing. On the other hand, I've definitely had patients and families that have had the chance to have these discussions ahead of time. And the families will tell me, as their loved one is going through their experience, I am so glad that we talked about this. I know exactly what mom wants. I know exactly what she needs. And it is hard, and it's hard for me, but I am so confident that I'm doing exactly what she wants. And that's not only a gift for the patient, that is a gift that you leave with your family with, like, forever. It's such a wonderful thing to do for your family.
Well said. This question gets into that too. How do you prepare families for the death of someone in your family? How do you prepare other family members for that?
You know, I think that to some extent it's something that is hard to ever prepare for, because everybody handles it different. And so I think in terms of preparation, what we can do as a medical community is really turn back and face the patient and the family and say, what are you worried about? What are you concerned about? What is important to you at this time? And if we can help them answer those questions, then we can maybe dissipate some of that worry and help them embrace the things that they value, so that they can focus on their values in that time. And so it looks a little bit different for everybody, but that process of helping people identify what's important to them and focus on what matters most is, I think, really central to this process.
Anything to add, Dr. Copeman?
Yeah, we have there's something that we have started now up on the range, and it's becoming more and more popular around something called palliative care. Okay, and patients will say, what is palliative care and what is hospice care? And when that question you ask is so right there with what palliative care is. So I'll explain it to you. So when somebody has chronic illness, we know that they're not going to go away. They tend to progress. Palliative care, our specialty is symptom control, maximizing everything we can, knowing that the disease is going to progress. When the disease progresses to where, in our best estimation, there's 6 months or less of life left, then it's hospice care. One of the things that we do when somebody is diagnosed with terminal and progressive illness is that we will begin palliative care, not hospice care, because palliative, you're still getting treated for things, but all those things that Amy talked about are started then, and all the things in your question, we start preparing for end of life. We start getting things in order. We try to maximize symptoms, and that's the beauty of our program.
When does, we know that hospice care, usually we try to guesstimate around 6 months.
Mm-hmm.
How about palliative care?
Palliative care, we look at when patients have 2 to 3 years in our best estimate of life. 6 months is hospice.
Okay, thank you.
Mm-hmm.
I think a lot of people don't quite understand the difference between those two.
They don't, and that's it can be very confusing.
Mm-hmm. Another thing to ask your doctor or
Yep.
people in the clinic.
Yep.
This is a great question, and I've run into this many different times with my own patients. What happens when the person has an advanced care directive and their family disagrees with what should be done? So they're not agreeing with the advanced care directive.
Thanks for looking at me for that one. Yeah. So that does happen sometimes, and that's why this advanced care planning idea is so important. Sometimes patients know what they want and identify it, and then aren't talking to the families about it, and then that creates some competing desires at that time. I think ultimately in the medical field, our goal is always to go with what the patient wants in general. And even when we're talking to the family, we're not talking to the family about what the family would want for the patient. We ask the family to tell us what the patient would want for themselves if they were right here sitting with us around a table. And sometimes those are really difficult things to balance. I know I've had issues with family where they might want one thing, and I love them, they're my family member, I don't want them to die, and I have my own needs around that. And I think what we try to do as a system is to try to help come together around the patient and what their goals are and what their values are, and to try to get everybody looking at that same frame. And people can have different perceptions about that, but the goal is to try to work to get everybody on the same page.
I think it really points out that a key or one of the most important pieces about these directives isn't just filling out a paper, but getting families talking about it and getting other members of the family on the same page.
Yes, and that is big. I have seen sometimes families absolutely torn apart over advance directives. And a classic scenario was when someone did not fill them out, and then they're terminally ill, incapacitated, and one side of the family wants this done and another side wants the other side done, and it becomes very, very difficult. And who makes that decision? And so if there's family members that disagree, the biggest where we see that come is mostly when patients are imminently dying. Because sometimes you see guilt where family members that have not been there for their loved one, and so they come in and they want everything done, whereas those that have been with them understand that the disease is terminal and the likelihood of them surviving for any length of time is small. And so, like Amy said, the most important thing is engaging your family. But the other thing is that when this happens, a lot of times we sit down and have a family meeting. And because us healthcare professionals, the social worker, can at least explain to the family members why those decisions were made, why we're honoring those, and why the interventions that they're wishing is not going to change the ultimate outcome. And so I reinforce wholly what Amy's talking about is engaging the families long before that situation arises.
Absolutely. If I had one tagline for this show, I would say advanced care planning, it's not a document, it's a conversation.
Right. And I forgot my thought. Let's get back to these questions that people are asking. What resources are available for writing an advanced care directive? I'll ask you, Dr. Copeman.
The first thing is that when you're doing that is there's all these different forms, and we give them out in our clinic visits that go through the details of that, but also there's a lot of stuff online, and that's the starting point. And the other thing is that if you're looking at a living will type thing, that can be started even at an attorney's office. But personally, I think the best place to start is with your doctor.
Right, and they can guide you, and they'll know your resources too.
Yep, exactly.
They'll be helped to guide. And remember, there are other services like legal services, legal aid in our state that also can help without all the cost if you can't afford these things, because they are so important.
Exactly.
Right. We kind of answered this one, should everyone over 25 have a living will?
In my opinion, yes. Actually, I can say I feel so strongly about this. We do this with our medical students, even at the medical school. Not to say that they have to have it signed and notarized, but that we ask all of them to look through those forms and to think about it. And it's really, I've received a lot of really positive feedback from them, that it's actually really beneficial, that they hadn't thought about that before, and they're glad that they did. And a lot of times it prompts not only discussions in themselves, but also discussions with families. And I think that also is a value of having younger people do it, because they think about the questions for themselves, but it also helps them to think about, well, do I know what my mom and dad would want? Do I know what my sister would want? Do I know what my significant other would want? And those conversations are so helpful.
I think I know what I was thinking. That besides guilt that people have coming in, family members coming in, I think there's a lot of fear. People are just afraid.
They're afraid. And it's a human response to not want to lose your loved one.
Exactly.
That's perfectly natural.
Yeah. So what should I think about when choosing a healthcare representative, the power of attorney? What's some of the conversations that I should have with that person? I'll ask you, Dr. Greminger.
That is such a great question. I really appreciate that. I think that when I talk to people about that, it's not necessarily the person that they feel like it should be. Like, I don't think that just because you're married, it should necessarily be the spouse. It's somebody that you can talk to this about ahead of time, that knows what you want, and that will be able to follow what you want. And sometimes the people that we're very close to, that might be challenging for them. And so I think that those are the things that I ask people to consider. Who knows what you want, who can handle that role, who is able to follow what you want, and who is okay with it. There are also times where people say, I know that this person really loves me and would try to do what I want, but it just might be too much for them. So it's also important to consider if the person is able to kind of handle that and be okay with that role.
Exactly. That I echo that. It doesn't always have to be your spouse. Like Amy said, it's someone that you would entrust to make a rational decision and to make known what your wishes are.
Right, it can be too painful sometimes.
It is,
people
and
are
I've had
closest to
patients
you.
with that says, I don't really want my spouse because it would be really hard for them.
Mm-hmm. I've had patients feel like they were causing a death by following through on the orders.
Mm-hmm.
Yep.
Yeah, so good thing to think about. At what points in life should advanced care directive be updated, Dr. Copeman?
They should be updated whenever, I think what will back up a step is that they can be changed. Once it's done, if you do it at age 45, that does not mean that has to be the same thing at age 65. They can be changed.
And you just chose those numbers.
I just chose those numbers, yes, as an
Yeah.
example, I'm sorry. Is that it's something that's fluid and it can change at any time. I honestly think it's good that when people are diagnosed with illnesses that they may not have had before, and just periodically to review what you want your care to be, and it can change.
I totally agree with what you're saying. I usually, once people have it written down, I encourage them to update it on the once a decade.
Oh yeah.
And once, if there are big life-changing events, like new diagnoses, or if they've been recently in the hospital, a lot of times, and that hadn't been something that they've been through before, a lot of times I think it can be helpful to update it.
Yeah, and to be honest with you, almost every time that someone is admitted to the hospital, it's updated because it goes as a physician's order on record. So
right on the front of the chart oftentimes.
Right on the front of the chart,
Yep. This person brings up a good question. My husband and I have an advanced directive at St. Luke's. How would my children know or learn this? And the point being that it should have been talked about.
Yeah.
You should be talking about with your children, with your family. And even if you choose someone else to be your power of attorney, they should probably be talking with the people who are closest to you.
Exactly.
So it's not a big surprise.
Exactly.
Yeah.
Yeah.
I've had times where it's been a surprise, and I think it's always better when it's not a surprise. It's better if people kind of know what's coming.
Here's a common misconception. If I have a living will, can doctors still resuscitate me?
You know, it all depends on the situation. The one example I think of is that anybody that's having surgery, a lot of times their advanced directives are reversed because things can happen that are completely reversible. You know, let's say your blood pressure drops, because of the meds, but that's something that's reversible. Or let's say somebody comes in and they mistakenly took too many of their opioids. That's a reversible thing. So a lot of times we still will resuscitate based on that because it's reversible.
Right.
I would say it depends on what your living will
Exactly.
says. So if I'm in my 20s, my living will might say that I want everything to be done, and this is a good person to ask, and you know, kind of thinking maybe about some serious situations. But very often, younger people with living wills do want to be resuscitated, and that's perfectly fine. So I do not think at all that having a living will is contrary with being resuscitated. It really depends on what you want and what you specify in that care.
We don't have much time left, but I do want to get this question in because it's really important. What's the difference between home hospice, hospital hospice and hospital hospice. I'm going to let you answer that, Dr. Greminger, because I know how much you love this topic.
I do. You do know me well. So what I tell my patients is hospice is a program, not a place. And so hospice can care for you at home, and it can care for you in the hospital, depending on what your needs are. It can
and
care
your family's needs.
And depending on what the family's needs are. It can vary depending on your time in hospice too. We have patients that come to our hospice program and they start off in home and maybe they get some more symptoms and then maybe they need to go to the hospital for a little bit to get those managed. And then maybe they go back home again, depending on what their goals are and what their wishes, hopes, and dreams are. We have patients in nursing homes that are on hospice programs. So I think that's such a great question. It's a question that a lot of people do think about hospice as a place, but hospice is a program that cares for you regardless of place.
Thank you, Dr. Greminger. We have about 10 seconds. Do you want to add anything in 10 seconds?
I was just going to say exactly what Amy had said.
Thank you very much. I think it's really important. As you said at the beginning of the show, what's most important is that people realize that they should be talking to their doctors about this if their doctors aren't talking to them, or their care providers in general. And it's really about autonomy, our right to control what happens to us at the end of life.
Absolutely. You said that so well.
Yes.
Thank you.
Thank you. I want to thank our panelists, Dr. Jeff Copeman and Dr. Amy Greminger, and our medical student volunteers, Katie Benson, Katie McLaughlin, and Abby Rader. Please join Dr. Ray Christensen next week for a program on diabetes, when his panelists will be Dr. Nahi Kalbawi and Dr. John Wood. Thank you for watching, and good night.